Trench foot, the non-freezing tissue destroyer. Trench foot, also known as immersion foot, occurs at temperatures between 0 to 16 degrees Celsius, which means tissue damage happens without freezing. It requires continuous wet conditions for minimum 10 to 14 hours. During World War I, the British Army documented over 20,000 cases, with some battalions experiencing 30% casualty rates from this condition alone. Matter of fact, this exceeded many battle wounds, though most people don't realize you don't need freezing temperatures to lose tissue. The mechanism begins with cold-induced vasoconstriction, where peripheral arterioles constrict, reducing blood flow to feet by 80 to 90% as core heat conservation response. As exposure continues, prolonged ischemia causes tissue oxygen delivery to drop dramatically. Anaerobic metabolism increases, creating lactic acid accumulation. After 12 to 48 hours, endothelial cells lining blood vessels swell, causing tight junctions to break down. This makes vessel walls leaky, letting plasma proteins escape into tissue while fluid accumulates, causing edema. On top of that, microthrombi form as endothelial damage triggers clotting. Platelets aggregate while fibrin deposits block small vessels, progressively worsening ischemia. If that wasn't enough, the post-exposure hyperemic phase occurs hours to days after removal from cold, when vasoconstriction suddenly releases. Massive blood flow returns, creating reactive hyperemia, where feet become intensely red. Skin feels hot to touch, producing pounding, throbbing pain described as feet on fire, which is not particularly comfortable. Matter of fact, severe edema can cause feet to double in size. Skin stretches tight, developing blisters, while inflammatory cytokines including IL-1, IL-6, and IL-8 release as neutrophils infiltrate, causing oxidative stress. The real danger is chronic consequences, where permanent neuropathy develops. Sensory changes persist with numbness or hypersensitivity, producing burning sensations lasting years or permanently. Vasomotor instability creates cold hypersensitivity, where feet hurt intensely in mild cold. Raynaud-like phenomena develop with color changes from white to blue to red. On top of that, hyperhidrosis occurs, where feet sweat profusely even when cold, due to autonomic dysfunction. Documented cases resulted in bilateral below-knee amputation, demonstrating this condition isn't just uncomfortable, but can be limb-threatening. Prevention requires keeping feet dry with sock changes every 4 to 6 hours if damp. Keep in mind, the British Army reduced trench foot by 95% by 1916 through systematic prevention. This included daily dry sock delivery in waterproof bags with 3 pairs per soldier. Mandatory buddy system foot inspections meant soldiers checked each other daily. Commanders were court-martialed for neglecting foot care. Whale oil or modern petroleum jelly application creates waterproof barrier. Waterproof boots with foot powder absorb moisture combined with encouraged movement to maintain circulation. Then there's an even more severe cold injury that involves actual freezing. If you want the fast, step-by-step cold survival protocol I use in the field, grab the free PDF in the first comment. No sign-up tricks, just the checklist. Frostbite, the ice crystal cascade. Frostbite begins when tissue temperature falls below minus 0.55 to minus 2.2 degrees Celsius. Ice crystal formation occurs in both intercellular and intracellular spaces, creating direct mechanical damage to cell walls. The freezing happens through 2 distinct patterns, creating different destruction mechanisms. Rapid freezing from flash freeze or direct cold contact creates intracellular ice formation where temperature drops so fast cells cannot equilibrate. Water inside cells freezes before it can leave, forming large, jagged, randomly oriented ice crystals. These crystals pierce cell membranes, damaging mitochondria, endoplasmic reticulum, while disrupting protein structure. Lipid membrane lipoproteins denature, causing immediate cell death, producing rupture, which is pretty much irreversible. reversible. However, slow freezing creates extracellular ice formation, where water freezes outside cells first. Ice crystal formation creates osmotic imbalance because ice is pure water, excluding solutes. This makes extracellular space hyperosmolar, pulling water out of cells, causing dehydration. Intracellular solute concentration rises dramatically, while cell volume decreases, creating membrane collapse. Eventually, smaller intracellular ice crystals form. On top of that, electrolyte chaos develops as potassium, sodium, calcium concentrations become toxic. All cellular processes get disrupted, destroying enzyme function, which is a serious struggle for tissue survival. Then there's vascular stasis phase, from continued plasma leakage. Blood vessels spasm, then dilate, leading to stasis, coagulation, creating shunting. Cold damages endothelial cells as ice crystals puncture them, causing swelling, then death, making vessel walls permeable. Fluid escapes, creating massive edema, while tissue pressure increases, compressing vessels. Red blood cells clump together, making blood viscous. Microthrombi form, blocking small arteries, so tissue loses all oxygen supply through complete ischemic injury. If that wasn't enough, arteriovenous shunting develops, where blood bypasses capillary beds, going directly from arteries to veins. Continuing further, the late ischemic phase, occurring hours to days after thaw, produces reperfusion injury as second wave of destruction. Progressive dermal ischemia continues despite rewarming, as vessels remain blocked by clots. New clots continue forming. Neutrophils invade tissue, releasing destructive enzymes, including proteases, that digest tissue. Elastases break down connective tissue. Inflammatory mediators release, including thromboxane A2 as vasoconstrictor, creating platelet aggregation. Prostaglandins PGF2 alpha acts as vasoconstrictor, while bradykinins cause pain, creating vascular permeability, producing more tissue damage. Matter of fact, reactive oxygen species generate, including superoxide and hydroxyl radical, destroying cell membranes, DNA, through lipid peroxidation. Progressive microvascular thrombosis continues as clotting cascade activates. Platelet aggregation occurs further, compromising blood flow. Even worse, fourth-degree frostbite affects skin, subcutaneous tissue, muscle, tendons, where ice crystals penetrate all tissue layers. Muscle fiber necrosis develops alongside tendon destruction. Bone marrow freezing occurs with periosteal damage. In children, growth plate destruction happens. Muscle death through rhabdomyolysis releases myoglobin, creating kidney damage risk. Bone damage through osteonecrosis develops. In children, growth plate destruction causes permanent limb shortening, creating deformity. The real danger is joint destruction, where articular cartilage dies, making arthritis inevitable. Joint dysfunction occurs, while nerve destruction produces complete sensory loss. Motor function loss happens, requiring amputation, with demarcation taking 3 to 6 months. Autoamputation may occur, where limb dies, then falls off, which isn't ideal. The thaw-refreeze catastrophe produces exponentially worse outcomes. First freeze creates initial ice crystal damage, causing cell membrane disruption with vessel damage. Then thaw occurs, where ice melts, letting water redistribute, allowing cells to partially recover if damage not too severe. However, refreeze creates new ice crystals forming in different locations. Previously undamaged cells now freeze as crystals form along new planes, creating additional mechanical destruction. Vessel damage compounds with each cycle, adding cumulative damage. More cells get destroyed, while more vessels thrombose, creating greater final tissue loss. In fact, studies show thaw-refreeze injury results in 2 to 4 times greater tissue loss compared to single-freeze injury. If refreezing is possible, do not thaw frostbite. Keeping tissue frozen for hours while evacuating is better than thaw-refreeze even once. Prevention requires a 3-layer system with base layer of merino wool or synthetic wicking moisture away from skin. Keep in mind, wet skin freezes 25 times faster than dry, which is a serious serious struggle to manage. Mid-layer of fleece or down creates dead airspace. Outer layer of waterproof, windproof, breathable membrane blocks convective loss. For extremities, mittens provide more warmth than gloves because fingers together share heat. They have less surface area with larger air pocket generating more metabolic heat. Boots requiring 400 to 1,000 grams insulation, depending on activity level, need waterproof membrane. They need room for thick socks without compression. Boots too tight compress insulation, causing frostbite, which isn't much better than direct cold exposure. However, frostbite takes time to develop, whereas the next mechanism can kill in under an hour. Hypothermia, the progressive organ shutdown. Hypothermia begins when core body temperature drops below 35 degrees Celsius. The body loses heat through conduction from direct contact with cold surfaces, convection, where moving air carries heat away, radiation through infrared emission, and evaporation from respiration. Water conducts heat 25 to 30 times faster than air, making wet conditions particularly dangerous. Mild hypothermia, 32 to 35 degrees Celsius. Metabolism increases trying to generate heat, while cardiac output initially rises. Hyperglycemia develops from stress response. Cold diuresis occurs where peripheral vasoconstriction increases central blood volume, making kidneys increase urine production. Initial tachycardia develops, then progressive bradycardia as temperature drops. Confusion appears as earliest cognitive sign alongside slurred speech, amnesia, and apathy. Fine motor skills deteriorate, producing fumbling and clumsiness. Intense shivering represents maximum heat production effort, though impaired judgment prevents victims from recognizing hypothermia. Moderate hypothermia, 28 to 32 degrees Celsius. Shivering cessation is the most dangerous sign, indicating body heat production has failed through glycogen depletion, muscle fatigue, neurological impairment, and hypothalamic dysfunction. Progressive bradycardia occurs where hypothermia decreases depolarization of cardiac pacemaker cells, not vagally mediated, therefore refractory to atropino. Heart rate drops to 30 to 40 beats per minute. Cardiac output declines severely, reducing mean arterial pressure. ECG shows J waves, also known as Osborn waves. PR and QRS intervals prolong, increasing arrhythmia risk. Atrial fibrillation becomes common below 32 degrees Celsius, while ventricular fibrillation risk increases dramatically below 28 degrees Celsius. Rough movement can trigger ventricular fibrillation, causing cardiac arrest. Severe hypothermia, below 28 degrees Celsius. Profound bradycardia or asystole develops. Heart rate drops below 30 beats per minute, or cardiac arrest occurs. Ventricular fibrillation represents most common terminal rhythm around 28 degrees Celsius. Mechanical stimulation, including rough handling, can trigger ventricular fibrillation. Death typically occurs around 20 degrees Celsius core temperature, where extreme cold disrupts the sodium-potassium ATPase, making membrane potential unstable, creating lethal arrhythmias. Paradoxical undressing occurs in 25% of hypothermia deaths. Victims remove clothing despite freezing through hypothalamic malfunction, where temperature regulation center fails, misreading body temperature, or vasomotor exhaustion, where peripheral blood vessels suddenly dilate, creating rush of warm blood from core to extremities, making skin feel warm. Terminal burrowing behavior occurs in approximately 20% of victims following paradoxical undressing. Victims crawl into small enclosed spaces triggered by primitive brainstem behavior when core temperature reaches 28 to 25 degrees Celsius. Prevention requires cold principle. Keep it clean and dry because moisture multiplies cold injury. Avoid overheating because sweating creates wet clothes. Wear loose layers because tight clothing constricts blood vessels. Keep it dry with regular moisture checks. cold shock response produces death in minutes when water below 15 degrees Celsius contact skin. Subepidermal cold receptors, located 0.18 millimeters below skin surface, respond within milliseconds. Greater body surface area exposed creates stronger response, triggering gasp reflex. Cold receptors signal spinal cord, then respiratory center, causing 2 to 3 liters of air involuntarily inhaled. If head is underwater during this gasp, water aspiration causes instant drowning. Hyperventilation phase, lasting 0 to 3 minutes, causes respiratory drive to increase 600 to 1000% above baseline. Breathing becomes rapid, creating shallow, uncontrollable hyperventilation peaking around 30 seconds. Respiratory frequency increases dramatically through tachypnea. Minute ventilation can exceed 100 liters per minute compared to normal 6 to 8 liters per minute. Breath hold time plummets from 60 seconds on land to 10 to 23 seconds in cold water. Hypocapnia develops from excessive CO2 exhalation, causing respiratory alkalosis, making blood pH rise. Cerebral vasoconstriction occurs as reduced CO2 causes brain blood vessels to narrow, producing cerebral hypoxia. Dizziness results alongside confusion, creating panic amplification. Direct drowning occurs because uncontrollable gasping underwater equals water aspiration. Lethal volume for seawater is only 22 milliliters per kilogram body weight, approximately 1.5 liters for 70 kilogram person. Swimming failure develops as hyperventilation makes coordinated swimming impossible. Cardiovascular storm produces massive sympathetic activation. Peripheral vasoconstriction shunts blood from periphery to core. Sympathetic nervous system releases norepinephrine, activating alpha-1 adrenergic receptors. Blood vessels in skin and hands constrict to 10 to 20% normal diameter. Skin blood flow drops from 250 milliliters per minute to less than 20 to 50 milliliters per minute. Hands lose dexterity within 10 minutes, while fine motor skills become impossible within 3 to 5 minutes. Tachycardia develops where heart rate increases 2 to 3 times normal from 70 to 120 to 180 beats per minute. Hypertension occurs where systolic blood pressure can rise 30 to 50 millimeters mercury through vasoconstriction, increasing myocardial oxygen demand, triggering myocardial infarction in vulnerable individuals. Diving response conflict creates most dangerous mechanism where both cold shock responses activate simultaneously during submersion, producing autonomic conflict. Sympathetically driven tachycardia opposes parasympathetically mediated bradycardia, producing cardiac arrhythmias responsible for deaths previously wrongly ascribed to drowning or hypothermia. Trigeminal nerve stimulation from facial cold receptors triggers parasympathetic response, producing bradycardia, apnea, and peripheral vasoconstriction. Electrical chaos develops in heart. Cold shock says speed up through sympathetic tachycardia, while diving response says slow down through parasympathetic bradycardia, producing supraventricular arrhythmias including atrial fibrillation, ventricular arrhythmias including premature ventricular contractions, ventricular tachycardia, and fatal ventricular fibrillation. Conduction blocks occur including sinus arrest and atrioventricular block, causing syncope or sudden cardiac death. Studies revealed nearly 30% of seemingly unexplained drowning victims had cardiac ion channel mutations, including long QT syndrome, making them vulnerable to fatal arrhythmias triggered by cold water immersion with swimming. LQT1 genotype makes swimming gene-specific trigger through abnormal ventricular repolarization, producing torsade de pointe, then ventricular fibrillation. Most drownings in cold water occur in the first 15 minutes, not from hypothermia, which takes 30+ minutes for unconsciousness, but from cold shock gasp reflex, autonomic conflict arrhythmias, and swimming failure. Effective swimming becomes impossible at 10 minutes, even for strong swimmers, with complete motor failure at 15 to 30 minutes. Prevention requires always always wearing a life jacket near cold water, preventing cold shock drowning as single most important water safety measure. Habituation through as few as 5 to 6 brief cold water immersions of 2 to 3 minutes each can reduce cold shock response by 50%. Respiratory frequency shows greatest reduction, though cardiac responses are less affected. Peak protection occurs after 5 to 6 exposures, with still 25% reduced response 14 months later, requiring maintenance with occasional exposure.
Before you click away, get the Cold Survival Protocol. It turns everything in this video into a 10-minute action plan you can follow even while panicking or losing dexterity. Link below. Up next, learn how to get warm without fire. The video is up on screen.